Okay, I'm going to go ahead and get started. My name is Mary Buffington. I'm an assistant professor of internal medicine in the section of nephrology. And today I want to talk about medical therapy versus renal revascularization and the treatment of renal artery stenosis. And I have no conflicts of interest, and we need to talk about identifying patients with renal artery stenosis, discuss the medical therapy and revascularization treatment options, and importantly, to identify those patients on medical therapy for renal artery stenosis who are at risk for treatment failure and who may benefit from revascularization even if they've been stable on therapy for a while. So renal artery stenosis is the narrowing or complete occlusion of one or both renal arteries, and it results in hypertension, ischemic nephropathy, and cardiovascular complications such as pulmonary edema. And it is at a certain critical juncture at which it causes these things. Ischemic nephropathy is a chronic kidney disease resulting from renal artery stenosis and decreased perfusion. And renovascular hypertension is hypertension mediated by high levels of renin and angiotensin II produced by an underperfused kidney. So the prevalence is about 1 to 5% in patients with hypertension. And in persons more than 65 years of age, a prevalence may be as high as 7%. And then they did in an analysis of 397 patients during a drive-by, doing a drive-by renal angiogram during angiographic evaluation of the coronary arteries. They saw that 31.7% had a 50% stenosis, and the bilateral renal artery stenosis was at 9.6%. But if you look at those subsets of people with a much higher atherosclerotic disease burden, then the prevalence is higher. So this is a meta-analysis of 40 studies looking at the prevalence of renal artery stenosis, looking at more than 15,000 patients, and with patients with that had at least a 50% stenosis in the renal artery, looking at a pooled prevalence rate. And so in total, the prevalence was about 15% for unilateral and 4.2% for bilateral renal artery stenosis. But as you looked at more cardiovascular issues, people with peripheral vascular disease had up to a 25% prevalence with a 13% bilateral renal artery stenosis. And people with an abdominal aortic aneurysm had more than 30% prevalence with 12% bilateral renal artery stenosis. So those patients with a higher atherosclerotic burden may be at much greater risk of having renal artery stenosis. And then they broke, in that same study, they broke it down by the extent of disease in the coronary vessels. So a patient with one vessel disease may have a 5.5% prevalence of renal artery stenosis, but in patients with three vessel disease, it's a 15.1% prevalence. So as the atherosclerotic disease increases, then the renal artery stenosis increases. So the etiology can be atherosclerosis, that's usually in patients more than 45 years of age, or fibromuscular dysplasia, which can occur in women less than 50 years of age, which is non-inflammatory, non-atheromatous change in the artery. And I'm going to talk exclusively about atherosclerotic renal artery stenosis. So as the stenosis develops, the kidney adapts to a decreased blood supply. And oxygenation of the cortex and the medulla is preserved with moderate to severe decrease in perfusion pressure and reduction in blood flow. And this usually requires an inclusion of up to 70-80% stenosis to cause cortical hypoxia. And hypoxia activates an inflammatory and fibrotic process. Decreased GFR occurs when the occlusion affects the entire renal mass. That's when you have bilateral renal artery stenosis or renal artery stenosis to a solitary functioning kidney. And decreased perfusion activates the renin-angiotensin system. So when you have activation of the renin-angiotensin system, you have increase in angiotensin II. That'll give you a release of aldosterone and ADH, which will cause you to retain sodium and fluid. And at the same time, the angiotensin II provokes thirst. So you'll have volume, an increase in the volume as a result of that, but also you'll have cardiac and vascular changes and systemic vasoconstriction, because angiotensin II is a vasoconstrictor, but it also can provoke the release of endothelin and sympathetic vasoconstrictors. So looking at the unilateral renal artery stenosis model, the stenosed kidney has an increase in the renin-angiotensin system, and it leads to angiotensin II mediated hypertension. Well, the normal kidney has an increased perfusion because of the volume expansion due to the increased angiotensin, and that suppresses the renin-angiotensin system in that kidney, and it can suppress it overall. And there's an increased sodium excretion by the contralateral kidney due to pressure natriuresis, and a preserved renal function. An overall GFR is preserved, and so the GFR is maintained. In the setting of bilateral renal artery stenosis or stenosis to a solitary kidney, you have the decreased renal perfusion that activates the renin-angiotensin system. Because the kidneys are less able to excrete water and sodium, and also with the renin-angiotensin on board, then you have volume expansion, and that will turn around and increase arterial pressure and tends to inhibit the RAS system. And you can even have a normal or low angiotensin II when it's measured. So there are, just to look at the way these kidneys adapt to the stenosis, the decrease in their blood flow, there have been a couple of really interesting studies that look at how the kidney adapts, and that uses BOLD MR, or blood oxygen level dependent magnetic resonance, and that measures deoxyhemoglobin in the cortex and medulla, and they're looking at the gradient between the levels of deoxyhemoglobin in the medulla versus the cortex, and that provides an assessment of the local oxygenation in vivo. And R2 is kind of a coefficient that they come up with to measure the level of the deoxyhemoglobin. So a higher R2 value means that there's a higher level of deoxyhemoglobin in that area. So the couple of studies has looked at that to evaluate the degree of hypoxia in the post-stenotic kidneys, and they evaluated the capacity of the post-stenotic kidney to adapt to a decreased renal blood flow. And then another study evaluated the result when severe occlusion actually overwhelms that capacity of that kidney to adapt. So the first study is comparing a stenotic kidney to the contralateral kidney. So there are 14 patients with unilateral disease, and they also compared it to 14 patients with essential hypertension. And these patients had at least a 62 to 81% stenosis in this kidney. And you can see here that there is a loss of kidney volume here. There's a loss of kidney mass. So looking at this is the stenosed kidney, this is the contralateral kidney, and this is the kidney in the person with essential hypertension. And so they draw kind of a circle around here, and so this is not kidney. This gives you the scale of the BOLD MR. This is high levels of deoxyhemoglobin. This is low levels. This is a low R2, this is a high R2. So this is surrounding the kidney, there's no perfusion at all. This is the kidney around here. So there's no tissue here. This is essentially the kidney we're looking at. But looking at this essential hypertension kidney, you have a nice gradient here. This is a low R2, meaning there's a low deoxyhemoglobin. This is a higher R2, meaning higher deoxyhemoglobin, but this is in the medulla, and it's physiologic for the medulla to receive less oxygen than the cortex, okay? Comparing that to the contralateral kidney, you see that there still is a nice gradient between the cortex and the medulla, and even over here with the fairly significant stenosis, this gradient between the level of R2 in the cortex and the medulla is significant, showing that there is still perfusion to that kidney. So even though the kidney volume and the blood flow was reduced in the stenotic kidney, the tissue oxygenation reflected by the R2 values did not differ significantly. And what they were looking at was that there was a nice difference between the level of R2 in the cortex compared to the medulla, okay? So essentially, this kidney has a stenosed renal artery. It's getting a decreased blood flow, even to the extent that it has a lower volume, but it's adapting, and it is still perfused. So there's a tremendous adaptive mechanism. Then they measured the renal vein for oxygen tension. And what they found was in the stenotic kidney, the level of oxygen was even higher than in the contralateral kidney or in the essential hypertension kidney. And the thinking behind that was that with the lower volume, the decreased blood flow, there was less solute transport and less use of those receptors that would use energy and use oxygen. So, you know, that's an adaptive mechanism for the kidney in the setting of stenosis. Then there was another study comparing essential hypertension without stenosis, moderate stenosis, and severe stenosis with a loss of functional renal tissue. Okay, so the cortical R2 levels were elevated for the severe atherosclerotic renal artery stenosis compared to the other groups. And the severe vascular occlusion overwhelmed the capacity of the kidney to adapt. So this is looking at the kidney with the moderate stenosis. And the moderate stenosis had on ultrasound, had a velocity of about 350 centimeters per second, which is a pretty significant stenosis. But still, this gradient is maintained here between the cortex and the medulla, and it is adapting and it is oxygenating. But here is the kidney with the very severe stenosis with the velocity, the renal artery velocity of about 450 centimeters per second. And you see, you do not have that gradient. You have a very high level of R2 here. And then you also have high levels of R2 here in the cortex. So this is a kidney that has lost the battle. Its ability to adapt to the decreased perfusion has been overwhelmed. And then this is looking at a slide. So much of this writing comes from Dr. Textor at Mayo Clinic. And this is a slide from one of his papers showing the bold MR. This is normal, and you see a good gradient here. This is even a moderate. You see a fairly decent gradient there. And you look, and histologically, it's pretty well preserved here, even with this moderate stenosis. But here with this severe stenosis and severe renovascular disease, you see that there are fibrotic and inflammatory processes at work. So these changes are going on in the kidney. And this all depends on the ability of this kidney to adapt. So essentially, there's a spectrum of disease involved here. You can have, even with the moderate stenosis, you can have asymptomatic renal artery stenosis. It can be incidentally found in those drive-by angiograms. It can develop into a renovascular hypertension where you're getting high blood pressure caused by the increased angiotensin. And then you can get, also it can progress and you can have accelerated cardiovascular disease and congestive heart failure. You can have flash pulmonary edema, things like that. And then you can develop just the ischemic nephropathy. So you think about it along a spectrum, and the question is, where do you intervene along that spectrum? You know, that's the important question. You don't want to intervene too early because if doing an arteriogram with angioplasty or a stent, it certainly has complications, and you can have some unfortunate events occur. So you want to, for diagnosis, you want to have hypertension with features indicating secondary hypertension. This is diagnosing renovascular hypertension. So secondary hypertension is hypertension with an underlying cause in contrast to primary hypertension. And indicators pointing to secondary hypertension are severe or resistant hypertension that persists despite using 3 antihypertensives at an adequate dose, a sudden rise in blood pressure in a patient with previously stable blood pressure, age less than 30, non-obese, no family history of hypertension, or someone with malignant hypertension like with retinal hemorrhages, papilledema, heart failure, acute kidney injury, or the onset of hypertension before puberty. So findings consistent with renovascular disease are essentially those things. Also, if you have an increase in the creatinine more than 30% after an ACE inhibitor is initiated, that can indicate it. Diffuse atherosclerosis or renal asymmetry found on ultrasound can indicate a risk for renal artery stenosis, and recurrent episodes of flash pulmonary edema. So testing for renal artery stenosis should be done only if a corrective procedure would be performed. If a clinically significant stenosis was found. And so you want to have people with clinical features of secondary hypertension, not consistent with other secondary causes, no primary kidney disease, no primary hyperaldosteronism or pheochromocytoma, and you want to make sure that the circumstances are such that even if you found renal artery stenosis, you would want to do an intervention. So the gold standard for diagnosing renal artery stenosis is angiogram, renal arteriogram. It's invasive and has risk for complications, so you can also use ultrasound and Doppler ultrasound. And it has an 85% sensitivity, 92% specificity, and a peak systolic velocity of more than 200 centimeters per second is roughly equivalent to a 60% stenosis. Okay? CT angiogram has a 96% sensitivity, 97% specificity to find a stenosis more than 75%. MRA has a higher sensitivity, but with the proximal renal artery stenosis, its specificity is not quite as good. So prior to 1998, there are some uncontrolled, non-randomized trials that showed the benefit in blood pressure control with stenting of the renal artery. So when they did a lot of stenting of the renal artery, and they had some uncontrolled studies that showed, oh, here's a benefit. From 1996 to 2000, these percutaneous procedures in Medicare recipients increased from more than 7,000 in 1996 to more than 18,000 in 2000. And it was estimated at that rate of increase, they could be doing 35,000 a year by 2005. Based on these non-randomized, uncontrolled studies, case series, a consensus developed that the patients who benefited the most from having the renal artery stented was those patients with refractory hypertension, flash pulmonary edema, and decreasing renal function. Okay? And they also would stent asymptomatic people without those factors, but those were the factors being identified as the ones supported by some evidence. Okay? And actually in 2005, the ACC-AHA issued some guidelines, and they said stenting of asymptomatic patients had a level C evidence. So it wasn't, they said, it's really not supported by any kind of evidence at all. But so the CMS called for prospective randomized trials to evaluate the benefit of doing these angioplasties with stents. And so from 98 to 2000, we had 3 small randomized controlled trials that essentially looked at blood pressure. How did it affect the blood pressure? And they had a short follow-up, and they were not really using ACEs and ARBs at that time. So the blood pressure control was a little iffy. But essentially, 2 of them showed no difference in blood pressure control, and one of them had a very modest decrease in blood pressure long term for patients with bilateral renal artery stenosis. However, that benefit was outweighed by the complications of the stenting procedure. Otherwise, there was really no difference. And then in these studies also, here was a crossover of 22 patients from the medical treatment arm to the medical treatment plus stenting arm, because they thought these people fall in that category that will definitely benefit. Okay, so there's like a bias sending these patients over to that arm. Okay. And then starting in 2000, we've had several trials come out. Two, STAR and Astral were in 2009, Coral was in 2014. And essentially, over the past year or year and a half, there's really been a lot written about how to interpret these trials. What do these trials mean? Essentially, the STAR trial, it was looking at medical therapy alone versus medical therapy and stenting, the renal artery stenosis that was found. It looked at 140 patients. Its endpoint was a 20% decrease in creatinine clearance, 24-month follow-up. It showed no difference in outcome with increased complications. Now, only 46 of the 64 patients assigned to get the stent actually got the stent, and the reason was, you know, if they saw on their screening test that there was a significant stenosis, if they brought them in and did the angiogram and it was not significant, they didn't put the stent. Okay, so there was a problem with, you know, there was a discrepancy between the testing that they used to send them for the study and what they actually found when they got there on arteriography. ACE and an ARB was only used in 50%. And the Astral trial was pretty big. It's 806 patients, and they looked at the reciprocal of serum creatinine, which is another way to look at creatinine clearance, and a mean follow-up 34 months. No differences between the groups except for the patients in the stenting group and the stent plus medical therapy had a worse diastolic blood pressure. 40 to 50% of the people with the ACE and an ARB, so a lot of people were not getting adequate medical therapy for their blood pressure. However, this had an interesting inclusion criteria or exclusion criteria. If the patient could only be put in this study if the doctor was uncertain that he would benefit from stenting. Okay, so if the doctor was uncertain, you know, would the stent help? Would it not help? If they were uncertain, they could be in the trial. However, if the doctor felt like this treatment this treatment, stenting is called for in this patient, I'm not going to send him to be randomized. I'm going to send him to be stented. So they had kind of a selection bias there. So these 806 patients did not include those patients that the doctor thought would definitely benefit from the stenting. Okay? So then we have the Coral trial, 2014, 947 patients. It has a composite clinical endpoint, and we'll talk about that a little in just a minute. Mean follow-up of 43 months. Essentially, there were no difference in clinical endpoints, which was death, stroke, MI, anything like that. But the group treated with the stent had an improvement in the blood pressure of 2 millimeters per mercury, lower than the other group. There are some limitations with this trial also. The inclusion criteria was changed because of low enrollment. So where they initially had required a blood pressure of more than 155 over something, that was changed to, well, where they can have some chronic kidney disease instead, you know, also. So there are a few issues with the enrollment here. So looking at Coral, so 947 patients who had unilateral or bilateral renal artery stenosis. They had systolic hypertension despite 2 or more antihypertensive medications. However, the definition of resistant hypertension is persistent hypertension despite 3 medications. So they didn't really necessarily have resistant hypertension here, and they were randomly assigned to the 2 groups. So the primary endpoint was the occurrence of a major cardiovascular or renal event, a composite of death from a stroke, renal causes, MI, from a cardiovascular problem, stroke, hospitalization for CHF, progressive renal insufficiency, or the need for renal replacement therapy. And so the revascularization had no additional benefit in terms of any of these endpoints, but there was the blood pressure benefit. And then the Coral study stated that the Coral study shows that when added to a background of high-quality medical therapy, contemporary renal artery stenting provides no incremental benefit. But, you know, there's a problem with the subset of patients that they admitted into their study. They did not necessarily have resistant hypertension. Their renal artery stenosis may not have been to that degree that we saw in the bold MRI, where the R2 levels are very high in the cortex. They excluded patients who had been hospitalized for heart failure, CVA, unstable angina MI, and those are the people with atherosclerotic disease that are high risk of having the progression of disease. And they had a tremendous number of patients who were screened. More than 4,300 patients were screened but not randomized, and 200 were for physician preference. 800 patients refused, and more than 1,100, they didn't say why. So why are all these people not going into the study? It really is a limitation of the study. So then, looking at a meta-analysis of all of these 6 studies that we just looked at, plus 2 more that weren't published because it was a negative result, and they found that with these 2,200 patients, that there was really no significant improvement in systolic blood pressure, renal function, cardiovascular adverse events, or renal adverse events in the stenting group, okay? And there was a small decrease in the number of blood pressure drugs that the stenting group people had to take, but that was really the only benefit. And there were complications of the procedure, hematoma, and I think in the Astral trial, 1 person died of an infected hematoma and 2 others died after the procedure. So it really had a lot of complications there. So criticisms of these randomized controlled trials, there is a selection bias because they're excluding patients who are most likely to benefit from the stenting procedure. And we talked about that. In Coral, they excluded those, and in Astral, if the doctor thought they would really benefit, they just sent them straight to angioplasty. They didn't put them in the Astral study. But there are observational studies done before these randomized trials that show a benefit of the stenting in patients with the flash pulmonary edema, intolerance to optimal medical therapy of blood pressure control, failure of medical therapy to control the blood pressure, and a blood pressure elevation that increases over 6 to 12 months over a previous baseline. And those studies showed that the stenting resulted in a lower risk of death in patients with flash pulmonary edema, fewer cardiovascular events, and improvement in blood pressure control. So in 2014, they published a study based on a cohort of patients. These are patients where the data was collected prospectively, but it was analyzed retrospectively. It's a single-center prospective cohort, 467 patients with atherosclerotic renal disease, renal artery stenosis, more than 50%, 15 years of clinical experience, and they had to have one of these risk factors. The high risk factors was flash pulmonary edema, refractory hypertension, rapidly declining renal function. So they divided it into a subset of people with high risk factors and the subset of people with low risk factors, okay? The endpoints that they used were death, first documented cardiovascular event, and end-stage kidney disease. So looking at this, so they had a low risk subset here, 230, and this was observational, so the doctor treating them decided to either medically treat or send for stenting. And then they had a high risk group, 237, and they divided those into flash pulmonary edema, declining renal function, or refractory hypertension. Okay, and in each one of these, there were some patients who were treated medically, and there were some people who received the stenting for the renal artery stenosis. So in the pulmonary edema arm, the medically treated patients had a hazard ratio of 2.2 for death and 3.1 for cardiovascular events in this arm, the flash pulmonary edema. And so looking at this is medically treated, this is survival, this is medically treated, this is with revascularization. So there was a benefit in that group based on this study, and it's limited because it's not a randomized controlled trial. But then they looking back at this, they looked at this group, decline in kidney function and refractory hypertension. They didn't see, compared just to medical, they didn't see a benefit in the stenting in these two. But they looked at these two together. They combined these two. They found a subset of patients who had declining renal function and refractory hypertension. And in that group, there was a benefit. The stenting decreased the risk of death to a hazard ratio of 0.12 and a risk of cardiovascular event to 0.28. And this is looking at survival. And those patients with these two risk factors combined. So essentially, we know that this is a spectrum of disease. We're looking at tissue oxygenation. The kidney has an amazing ability to adapt to decreasing renal blood flow. Okay, it can adapt and maintain its tissue oxygenation. Then, after chronic disease or as the disease advances and the stenosis is more and more, you get tissue hypoxia, and then at some point you have overwhelmed the ability of the kidney to adapt. You have the induction of inflammatory and fibrogenic pathways, and essentially the prospective trials are looking at people in this group. They're the people who don't really have the worst hypoxia, because the people with the worst hypoxia are sent for the stenting. The observational reports, especially the early ones and then that retrospective one, they're looking at the patients who are at this end of the spectrum. And those indicate that there is a benefit to intervening. And you're never gonna, at this point, do you think they would ever randomize someone with flash pulmonary edema, decreasing kidney function? Would they say, hey, wait, let's put you, let's just medically treat this and see what happens? I don't think that randomized trial is ever gonna really happen. So essentially, that's kind of where we are with thinking about the pathophysiology, diagnosis, and looking at the randomized controlled trials. So treatment of renal artery stenosis. You have unilateral renal artery stenosis with one affected kidney, one normal kidney. You want to give antihypertensive therapy. ACE inhibitors and ARBs are the cornerstone of treatment of that. You need a statin, aspirin, encourage smoking cessation and glycemic control. For bilateral renal artery stenosis or stenosis to a solitary kidney, the randomized control trials show us that there's no benefit in stenting the stenosis in the absence of some high risk factor present, where something is changing, the blood pressure's out of control, the kidney function's going down, or there are cardiovascular events happening that are making you think we need to address this renal artery stenosis. So it's conservative treatment with patients with preserved renal function, blood pressure controlled, and no pulmonary edema or cardiovascular events. And then also, they call it the CORAL cocktail. This is what they gave the patients in the CORAL trial. Even the patients with bilateral renal artery stenosis really tolerated the ARB well. So they gave candesartan with or without HCTZ. Amlodipine was an add-on medicine, atorvastatin to treat the atherosclerosis, and aspirin. And statin, treating the atherosclerotic disease is really important because the probability of death or cardiovascular event is greater than the risk of needing renal replacement therapy in patients with renal artery stenosis. And there was just with regard to tolerance of the ACE and the ARB, there was a prospective observational study of 621 patients who really tolerated the ACEs and ARBs well. Even the patients with bilateral renal artery stenosis tolerated it well. And if they didn't tolerate it, if they went and had the angioplasty with the stent, most of those were able to tolerate the ARB after that. And there was a mortality benefit in those patients on the ACE or with a hazard ratio of 0.61. So you will think of revascularizing if there's a failure of optimal medical therapy to control the blood pressure, intolerance to optimal medical therapy, or recurrent flash pulmonary edema. Surgical revascularization is preferred in patients with complex anatomic lesions, if they have multiple small renal arteries, if there's some branching of the main renal artery, or if there's a need for aortic reconstruction near the stenosis, such that a surgical option would be better, like if there's just diffuse atherosclerotic disease at that area. In patients without evidence of advanced disease, medical management is preferable. It is, and we've talked about this, it's reasonable in patients with a short duration of blood pressure elevation, recurrent flash pulmonary edema. Stenting is reasonable for bilateral renal artery stenosis patients who have decreasing renal function that has no other etiology other than the progression of renal artery stenosis. So patients who are stable on medical therapy can have progression of stenosis. So essentially, keep your eyes open. You've diagnosed someone with renal artery stenosis. It's very stable. They're on their medications. Blood pressure is controlled. They're doing their kidney function stable. Follow them up every 6 months and make sure that there's not a change, because it can be that the kidney function will deteriorate, the blood pressure will increase, and it may be time to intervene with angioplasty and stenting in that case. So restoring blood flow after critical stenosis can reduce the cortical hypoxia, but it doesn't really reverse the inflammatory signaling that has been established, and it doesn't really reverse the microvascular disease. There can be some rarefication and obliteration that has occurred. So there are some investigational treatments that are being talked about. One is antioxidants to limit oxidative injury. There's a mitochondrial target peptide, SS31, that was given to protect mitochondria during the process of revascularization, and it really preserved kidney tissue. Endothelial progenitor cells can increase angiogenic factors, and mesenchymal stem cells can reduce cytokine expression. So that can help limit the damage to the kidney, and some even promote healing. So in conclusion, renal artery stenosis is can cause hypertension, and that's a secondary type of hypertension. Pursue the diagnosis if the patient has factors that would lead you to treat the stenosis. It's a renin-mediated phenomenon, so ACE and ARB should be the first-line drugs for treatment, but you have to be careful and monitor renal function. And following patients on medical therapy should be done very carefully, and refer for stenting if high-risk factors present later.
I think the weakness of that last study, the observational study that you showed, is that if you have many comorbid factors, you are less likely to get invasive therapy. You're more likely to get medical therapy. So the medical therapy is going to look bad in an observational study.
I think you're right, and a lot of people with this disease are 67 years old and older. And so you do have to balance the risk and benefits of an invasive procedure like this with, the potentially limited benefit that they would get.
In the past, I think before bone MRI, we used to talk about, the kidney size is less than 8 centimeters, or if you biopsy them and there's more than 30% fibrosis, then you probably should not do anything, just medical manage these patients, because there's no point stenting them. So this bone MRI, is that available? Is that something new we can use in place of a biopsy?
In place of a biopsy. Well, renal size is important because if it's 7 centimeters or less, then you're not likely to get any renal function back. I don't think it's widely available. I don't think you would do it. I don't know that a biopsy is really what you use to diagnose, ischemic nephropathy from renal artery stenosis.
No, you want to know whether you can save the kidney. So if there's still
Okay.
viable tissue in
Yeah,
the kidney, you
yeah.
can biopsy.
If it were available, yes. And another thing is if it's more than 7 centimeters, and also if the resistive index is less than 80, less than 0.8, then it's more than possible. So you may want to look at a resistive, the RI, to see. That might be a better indicator. Now, if we had bold MRI, that would be really great. That would be wonderful. Okay, well, thank y'all very much.